So, my name is Ludivine Munier. I'm the founder of Seikoya, which is the first method for diagnosing human factors, known both in France and internationally. I know that today, we don't have any competitors in this field, so I'm going to explain a little bit about what it is. Seikoya has been around for 10 years, so we've been developing this expertise since 2016. It's a brand and a method that is registered with the UMPI in Europe and internationally. We have a presence throughout France, and we are involved in university training programs, such as nursing schools and health professionals. We also had the good fortune, since April of this year, to have the Human Factors Framework published by the Haute Autorité de Santé, which has finally put a name to what you do and encourages the integration of non-technical skills into the training of healthcare professionals. So, the diagnosis of human factors allows you to get to know your patient in a different way. Up until now, we've talked a lot about physiology and anatomy. Now, we're going to talk more about the human side, which is different from anatomy. And the goal is to be able to explain to you why your patients drop out of follow-ups. I don't know. So I wanted to make this talk a bit more fun. So I'm going to ask you a few questions. First question, who here has a driver's license? Good, thank you. Second question, of those who have a driver's license, who has already driven on the highway? And who of those taking the highway ever took the wrong direction? At least half. We agree, right? Yes. Good. So you've all taken a direction without knowing where you were going. You agree. Do your care pathways offer that possibility? In your care pathways, do you have the option to tell patients, you come in, but we don't know where we're going? Not really, not really. And how many of your patients drop out? That's a tough one to answer. The latest studies show people start dropping out around 40 or 50 years old, right? That's a lot, but yes. So what's going on? I wanted to make this talk fun so you could really understand, in concrete terms, what human factors are, according to our diagnosis. The linguistics of a system uses a collective reasoning strategy. It's characterized by two functions that we analyze. You should know that in the Seikoya diagnosis, we analyze about 40 to 50 strategies. These are the ones related to bariatric surgery and have been identified by the Seikoya diagnosis. These reasoning strategies are quite clear to explain today. We have two ways of reasoning. One is option-based, needing possibilities and choices, like the other direction sign, which causes no trouble. And we have another way, which is more procedural. We need steps, things that are very structured, like the ink note here. And so, what about your own strategy? Individually, does it resonate with the system's strategy or not? Are you okay or not with using the same strategy as this one? In care pathways, like for obesity, if we transpose this, the instructions given in the pathway are mostly presented step by step, with something very structured. And that affects individual behavior, whether it resonates or not, in the same way, depending on how easily we accept the strictness of procedures. What I'm telling you is that you have patients who will need choices. And you'll have patients who need something that's very structured. And it's our job to be able to analyze that. So, what is the diagnosis of human factors? It's a method of gathering information based on listening to linguistic structures, which allows us to diagnose individual and systemic strategies. We can diagnose human factors, the care pathway, the multidisciplinary team, and the patient all at once. That means you can analyze how the patient functions. We can also tell you how your care pathway works. Does it cover all the patient's strategies? And in your care team as well, how do you function, and does that also cover all the types of patients you might have in front of you, all profiles? You should know that the method is based on several theories, such as Tom Chomsky's theory of language, the metaprograms of NLP by Robert Linder, and also the research of Roder Bell, who was an anthropologist for these theologies that cover America. That's the process. How is human factors diagnosed? It's mainly via phone, as mentioned. It uses a linguistic structure, so hearing patients is enough. In the care pathway, we work in several specialties, notably pathology. It's carried out by a Seikoya practitioner, who is originally a healthcare professional trained in the method, and the interview can last anywhere from 30 to 45 minutes. You then have an online report available on the Digital Health Data Security platform, which allows you to consult it. And we set up training for multidisciplinary teams to adapt the care pathway. We conducted research, but research is done regularly on health independence. Within our team, using all the data we collect and analyze, based on more than 5,000 patients, we worked on 4 strategies in particular that emerged as part of the barriers pathway. These include decision-making residue, which I gave you as an example, options, procedures, and we also worked on foundational treatment, our way of processing information, how we motivate ourselves, and how we organize the workflow. And what came out of this research is that 43% of your bariatric surgery patients have an options-based reasoning, which also means that 57% of your patients have a procedures-based reasoning. That is to say, when you have extremely structured pathways, 57% of your patients will find it easy to integrate, easy to reason in the same way, so they'll adapt easily. And you also have 43% of your patients who might lose interest or drop out. So when we make this diagnosis, we say, be careful with these patients, they need flexibility. That doesn't mean you have to review everything right away. It just means you can allow for flexibility within structure. Regarding motivation, we've observed that 45% of your patients have reactive motivation, which means it's an active motivation. In other words, 45% of your patients will need active follow-up that comes from external stimulation. For the information processing part, 62% of your patients need a lot of detail in the information you provide. I should also mention that 38% of patients prefer very general information. It's important to know that often, in your standard communications, the information is very general. So going over things several times with different people will lead to something more precise, more detailed, and we can fill in the gaps. This lack can be addressed with a more professional approach and repetition. And regarding the part, that is, the way the organization of individuals works, we found that 64% of your patients need a dedicated contact person. In other words, 75% of patients who are being followed in these care pathways need to have an identified point of contact, someone who will be the main thread throughout their journey. On the other hand, we still have 36% of patients who don't necessarily need a dedicated contact person. What this research shows is that the majority of patients have a vulnerability factor, which for us is, at the very least, part of the reasoning process. If we can take this into account with the diagnosis of human factors, we can limit the loss within the population. It's about responding to findings with the diagnosis of human factors in the economy and human factors in elective surgery. It's also about working on reducing the limits from 20% to 10%. It's about identifying at-risk profiles early so we can adapt accordingly. And it's also about adapting follow-up and communication methods to prevent disruptions in care pathways. When we train care teams and recipient teams, we really focus on this work with precise targeting and adaptation. So in practical terms, for example, we can implement sequential diagnosis early in the care pathway with tailored communication and a follow-up schedule that includes active reminders. A dedicated point of contact, but not all the time, really focusing on patients who need it. And a flexible care pathway, meaning standardizing it while allowing for adaptations for patients who tend to prefer options and need to make choices. And the goal of all this is to prevent disruptions in the care pathway, with better engagement and continuity throughout. Now, the limitations of the study is, in a way, retrospective. It's about feasibility in routine practice, how to integrate it, and at what point in the care pathway the role of a cooperative evolves. It's also about how the profiles evolve. Currently, we have ongoing research on stability. And so the outlook is to be able to see how this fits in with what's already in place. In other words, we're not here to replace or remove anything, but rather to clarify things, to work in complementarity with both psychologists, dietitians, the ETP workshops that are being run, and hospital ethics teams. It's about having an impact on long-term follow-up, with monitoring over 1 to 2 years. This needs to be measured. And then a multidisciplinary rollout, including training, especially for medical, surgical, genetic teams, psychologists, and others. The heterogeneous human factors show here that, in reality, 64% of patients have a profile at risk of dropping out. Early identification allows for increased prevention, tailored to the subject of communication, and not after the meeting, but rather beforehand. It's a lever for large-scale personalization. We're working with 5,000 patients. It can be applied quite easily as a routine of interest. Operating has turned into anatomy, and the company has turned into the patient. So Seikoya, that's 19 team members in data science this year. It's also a database of over 9,000 patients with a business eco-selection activity. We are certified that there is both the foundation and the intrigue. Thank you very much. Thank you very much for your attention.